So I'm very pleased to welcome back to the stage Shreya Patel. Shreya is a policy analyst at MiHIN and served as the host for yesterday's very successful legal summit, as she described this morning. She's worked with nationally recognized legal clinics, hospitals, excuse me, and policy centers to emphasize patient advocacy through policy initiatives. Recently, Shreya was appointed co-chair of our privacy working group for MiHIN's Operations Advisory Committee, where she routinely examines behavioral health issues related to opioid use and mental health services. And she will be moderating our panel on aligning physical and behavioral health with electronic consent to enable comprehensive patient-centered care. Please join me in welcoming back Ms. Patel.
Thank you so much for the introduction, Shelley. An alignment between physical and behavioral health care providers is essential to share patient information, diagnoses, and treatment strategies. With updates to consent laws in Michigan and nationwide, this alignment is now happening. In this panel, you will learn how Michigan's standard consent form enables this alignment and how patient-centered care is evolving to help build a true 360-degree view of the patient for all care team members. We've assembled a wonderful group of panelists today, so I will briefly introduce our first presenter. Phil Kurdonowicz is a specialist with the Policy and Strategic Initiatives section for Policy Planning Legislative Services Administration in the Michigan Department of Health and Human Services. Phil helps with coordinating health policy initiatives across state agencies and external partners. He specializes in policy projects that are related to behavioral health services, health information sharing, and privacy laws and regulations. He also participated in the Policy Fellowship Program at the Center for Healthcare Research and Transformation. Please join me in welcoming Phil.
Good afternoon. So thank you for the very kind introduction, and I'm very excited to be here with you today and talk about two of my favorite topics, sharing behavioral health information and integrating physical health and behavioral health services. And although I am up here, I am representing a larger team, both on sharing behavioral health information and integrating physical health and behavioral health services. We have many individuals within the department who have been contributing to this effort, and I would not be here without them today. So I thought it'd be best to start with a frame of reference. How are behavioral health and physical health services currently delivered in our state? So in terms of publicly funded services, there are 10 prepaid inpatient health plans in Michigan that are responsible for managing specialty behavioral health services. So that's services for individuals with substance use disorders, individuals with serious mental illness, individuals with intellectual or developmental disabilities, or children with serious emotional disturbances. Those 10 prepaid inpatient health plans contract with 46 community mental health service programs at the county level to actually deliver those services. And so those 46 CMHs either directly deliver those services, or they might contract with local providers to actually do the service delivery. And the Michigan Department of Health and Human Services also makes some direct payments to community mental health service programs. The prepaid inpatient health plans are also responsible for managing both Medicaid-funded and non-Medicaid-funded substance use disorder services. And sometimes they delegate that responsibility to the local community mental health service programs. So that's one side of the house. The other side of the house is managed by the 11 Medicaid health plans. They are responsible for managing physical health and mild to moderate mental health services. And they contract with a wide array of providers to actually deliver those services. So primary care, specialists, FQHCs, hospitals, just a wide variety of different providers. And finally, there are 5 state of Michigan hospitals. So we have 3 hospitals for adults, 1 hospital for children, and then 1 hospital that's a forensic center. So where's the individual in all this? Well, the individual receives services potentially from all these different providers, or a collection of these different providers. And what that means is that in Michigan, we have a fragmented system, both in terms of service delivery as well as the managed care structure. As you can see, there are two separate managed care structures for publicly funded benefits. So how we tried to integrate physical health and behavioral health services over the last few years. There's been a plethora of different health home initiatives over the last few years that have tried at the provider level to integrate services. So usually this involves case management for individuals who might have mild to moderate mental health needs, as well as chronic conditions or maybe serious mental illness and chronic conditions, leveraging electronic health records or other health information technology. There are a number of primary care providers, FQHCs, or community mental health service programs that have taken on this role and become health homes through a variety of initiatives, whether it's My Care Team, the 2703 Health Home Initiative, or SIM, and are trying to sort of bridge the divide at the provider level. There's also a set of initiatives that, for lack of a better term, is called we call the current financing structure enhancement. So that's, if we go back to the diagram for a second, trying to make the Medicaid health plans and the prepaid inpatient health plans work closer together. So one of those initiatives is the My Health Link initiative. That's for individuals who are duly eligible for Medicare and Medicaid. And there are 4 demonstration regions in the state that are testing out that model, and that's primarily through contracts. But funding stays separate. It's just through contracts and also what's called the Care Bridge. It's basically a care coordination platform, trying to make them work closer together. The other initiative is shared metrics, and that's an incentive program for the Medicaid health plans and the prepaid inpatient health plans to work together. And they're focusing on one specific metric right now, that's follow-up after hospitalization. Oh, there we go. So in terms of future models, there are a number of other health home initiatives that are coming online in the future, including opioid health homes, potentially certified community behavioral health centers, other initiatives. But there's also this larger initiative called Section 298. And it's been in the news quite frequently. It's a little bit controversial because it involves bringing together 2 separate managed care systems. But essentially what it's trying to do is, rather than have 2 separate managed care structures, one for physical health and mild to moderate mental health services, and another for specialty behavioral health services, the pilots attempt to achieve integration under the Medicaid health plans. So Medicaid health plans are responsible for all Medicaid-funded physical health and behavioral health services. And the goal there is to, if we align the funding streams, can we promote integration at the service delivery level downstream? That's the goal of the pilots. There's also a demonstration project which keeps those funding streams separate. I don't have time to, during this presentation, to dive all the way into it, but there are a number of different initiatives that we're trying or have tried to integrate care. And one thing that's become evident is, well, the goal of all these initiatives is to achieve better health outcomes for the individuals we serve. That's the common theme across all these initiatives. In order to do that, we have to become more effective in how we coordinate both physical health and behavioral health services. In order to do that, we have to increase the sharing of physical health and behavioral health information. And I say physical health information there with emphasis because sometimes physical health information does not flow as freely as it should under HIPAA. And what that means is that we also had to address a number of barriers related to privacy laws and regulations. So there's a wide variety of privacy laws and regulations out there. We're primarily going to focus on 3 today. So the first is HIPAA, which many of you are familiar with. It's generally very permissive of health information sharing. The second is 42 CFR Part 2. That's a federal regulation that governs the sharing of substance use disorder information. It's very stringent, requires written consent. The final statute is the Michigan Mental Health Code that has provisions that govern the sharing of both mental health records as well as substance use disorder records. It has historically been very stringent in how information has been shared, but recently, as of 2016, it's become a little bit more flexible, and I'll talk about that in a bit. So the challenge for a long time is that with all these different laws and regulations out there, no one could quite agree on What are the terms for sharing health information? What types of consent forms do we need? What type of legal agreements? And so the legislature took the first step and said, can we at least have a common consent form? So the individual doesn't have to run from one provider to office to the other to get a consent form signed to share their health information. The legislature passed Public Act 129 in order to accomplish this. It allows the department to adopt a standard consent form for sharing mental health and substance use disorder records, and requires providers and other agencies to accept and honor the standard consent form if it's presented to them. So it's really a way of unlocking the sharing of behavioral health information, both mental health records as well as substance use disorder records. So in terms of implementation, we have published the standard consent form. We are currently on version 4.1 and working towards version 5.0. Version 5.0, the draft was published on Tuesday. We have also developed a number of supplemental documents, either FAQs or educational documents, to help both consumers and providers understand when can physical health and behavioral health information be shared, what are the requirements around sharing that information, what are consumer rights, why is it important to share information. That's all available on the department's website. So we've tried to actively engage our partners and help educate them about how this information can be shared safely and responsibly. We've conducted education and outreach to many of our partners, and we've also enacted a number of different requirements into our contracts and policies to use the standard consent form. So in terms of the prepaid inpatient health plans and community mental health service programs that I mentioned earlier, we wrote into their contracts that they have to accept, honor, and use the standard consent form, because we really want to encourage them to adopt it, actively use it, and engage in health information sharing. So over the last 2 years, there have been significant changes in the privacy landscape here in Michigan. So the first is Public Act 559, and the second is the revised rule for 42 CFR Part 2. So in 2016, the Michigan legislature amended the Michigan Mental Health Code to allow for mental health records to be shared for payment, treatment, and coordination of care. So where before, in order to share mental health records, you needed explicit written consent, mental health records can now be shared for payment, treatment, and coordination of care, very much like physical health records. Now, to understand this, and what the change means is, we're going to jump in the time machine for a second and go back to actually 1965. So between 1965 and 1975, there was a rapid deinstitutionalization of individuals with serious mental illness. So we went from 17,000 individuals in state hospitals to 5,000. So a large drop in the number of individuals in state hospitals, and a large number of individuals returning to local communities, and unfortunately confronting stigma and discrimination and facing a number of challenges with reintegrating it into the local communities. So the legislature in 1973 passed a law in order to protect the privacy of the individuals who are returning to the community. And I just I bolded one section of the law right there, that a patient's right of privacy is held inviolate. Inviolate means not violated or shall not be profaned. So the legislature very early on recognized that there are special concerns around mental health records and individual health information. They then passed the next year Public Act 258 of 1974, which is called the Michigan Mental Health Code. That's the formal name. And that expanded on that section, still maintained the confidentiality requirements, but listed out a number of exceptions when mental health records could be shared with or without written consent. So over the years, that law has been refined and additional exceptions have been added on. So what Public Act 559 really represents is not an isolated event. It's really a progression in how our state law has evolved as individuals have returned to the community, as we've advanced community-based systems of care. There are reasons that mental health records need to be disclosed. And so Public Act 559 is part of that progression. It's also bipartisan. So many laws, as you probably have heard, do not always pass on a bipartisan basis. In the legislature, there are 110 representatives, 104 voted for this law, In the Senate, there are 38 senators, 37 of them voted for it. So this was a bipartisan consensus in terms of moving in this direction. The second change is 42 CFR Part 2. For those who were at the Health Law Summit yesterday, you probably heard plenty about this. So it really maintains the strict confidentiality requirements around the sharing of substance use disorder information, but it does allow a number of new flexibilities. And the goal, or SAMHSA's goal, was to encourage participation of substance use disorder treatment providers in integrated care models, allow for broader sharing of information under health information exchange, and allow for greater collaboration across the system. So the federal law still requires written consent, while state law, at least for mental health records, now allows for mental health records to be shared much like physical health information. So part of what I'm going to talk about is how healthcare transformation initiatives have helped or have profoundly shaped how we've approached sharing behavioral health information. So I talked about the MyHealthLink and shared metrics programs earlier. This is where the rubber really hit the road in terms of sharing behavioral health information. There's a strong interest as part of MyHealthLink is in sharing what's called an integrated care bridge record. It's basically a CCD. And then as part of shared metrics, there was a strong interest in having access to ADTs. And in order to do that and share mental health records as part of that process, we had to navigate privacy and consent laws. And so that's really where the rubber hit the road, and we had to figure out how do we operationalize the standard consent form in this framework. And it turned out to be way more challenging than any of us originally imagined. And so that's why we partnered with the National Governors Association through a technical assistance program to explore this issue and try to develop a statewide strategy about how do we leverage consent, especially the standard consent form, to allow for the sharing of this information as part of our healthcare transformation initiatives. At the same time, there were a couple of other initiatives happening at the same time. I've already talked about Section 298. The other initiative is called the Michigan Inpatient Psychiatric Admissions Discussion, and that could be a whole presentation unto itself. So suffice it to say, it's a statewide initiative to address systemic barriers to inpatient access to accessing inpatient psychiatric services. The thing that these two initiatives shared in common is that there was a strong emphasis on health information sharing, and there's a couple things that we heard. That we should leverage the standard consent form, that we need to strengthen our education and outreach efforts, that we need to actively engage consumers in these discussions, that we need to leverage health information technology where possible, including Care Connect 360, ADT notifications, and medication reconciliation, and that we should continue to collaborate with providers and payers on navigating this space. So all those recommendations we've been considering as part of the National Governors Association Technical Assistance Program, and it led to the development of at least a preliminary statewide strategy. So for 2018, this is where we're really focusing our efforts on improving the sharing of behavioral health information. So the first is improving the accessibility and usability of the standard consent form for consumers and frontline staff. So just to jump ahead here, this is version 4.1 of the standard consent form, as you could probably tell, and actually you probably can't read that. So there's a link at the bottom if you want to see an actual up-close version of the consent form. As you could probably see, it's very dense. It's written in legalese, and it has a 11.7 reading level, so very high. Most of our consumers that we're serving through our public programs, it's not very usable for them. And in fact, it's not very usable for frontline staff either. So we've made a very concerted effort to bring down the reading level and improve the usability. Version 5.0, which was posted as a draft on Tuesday, it's open for comment right now, is also posted on the department's website. We managed to bring down the reading level to 7.3. And we've reorganized the form substantially in order to really highlight information up front for the consumer. If I'm a consumer, I want to know, why are you asking me to sign this form? What's the benefit to me? What are my rights? And so we put that information up front. We also did some restructuring to make it more HIE friendly. So, sorry. I'm going to jump back there for a second. So that's one strategic goal as part of the plan. We're also planning to expand our education and outreach efforts, and we're looking at a few different methods for doing that. Encouraging providers and payers to fully implement Public Act 559. As I mentioned, that was a bipartisan piece of legislation. The legislature has encouraged us to move in that direction of treating mental health records more like physical health information. It's something that we are going to work with our provider and payer partners to more fully explore, and then continue to collaborate with the consent form work group as well as other stakeholders. So those 4 pieces are really part of what we call the trust framework, and we're hoping to build a technology on top of that, because you need to have technology and trust developed concurrently to really achieve effective sharing of behavioral health information. And so from a technology standpoint, we have 3 primary goals. One of them is to integrate behavioral health information into Care Connect 360. That's the state's web-based platform that we make available to providers and payers to assist with care management activities. So there's a strong emphasis on that. Also promoting the sharing of ADT information for inpatient psychiatric stays. So for physical health stays, the ADT notifications are already flowing. Historically, due to the mental health code, inpatient psychiatric stay ADTs have not been able to be transacted because of the mental health code. So now that the mental health code has been revised, this is a potential opportunity and could be really transformative. If we're talking about someone who's leaving a hospital after a psychiatric crisis, they are most vulnerable between days 7 and 30 as their medications start to run out, as maybe they're not connected with a follow-up clinical visit. If we can get ADT informations or ADT notifications for inpatient psychiatric stays in the hands of providers and payers, we could potentially follow up with that individual, make sure their medications are filled, make sure they're linked in with a follow-up visit. There's a real potential transformative opportunity there. The final piece is developing the capacity to electronically manage consent at the local level. So even though the mental health code has changed, there's still plenty of instances when consent might be required to share mental health and substance use disorder treatment records. Electronic consent management is still crucial in terms of our strategy as well as the overall statewide approach for improving the sharing of behavioral health information. So it's, it probably sounds a little bit contradictory. I'm going to actually speak to that in a second, but it's still an important part of our strategy, and we're really looking to some of our local partners to lead the way on this. So jump ahead. In terms of the last few years, what has really made me proud is that this statewide effort to standardize consent and improve the sharing of behavioral health information has been a collaboration amongst a wide variety of partners. So providers, payers, HIT and HIE vendors, as well as advocacy groups. A number of different individuals, including the ones in this room, have come together to develop the standard consent form, to implement it, to work towards integrating it into physical health, behavioral health integration initiatives. And that's really something to be proud of. What makes me anxious, and probably what you probably have guessed this, is that there is a conflict between Public Act 129 and Public Act 559. Public Act 129 really focuses on standardization and trying to leverage a standard consent form. Public Act 559 focuses on making the sharing of mental health records more akin to how we share physical health records. It's 2 different frameworks, and they're not going to be easy to reconcile, and they're not going to be easy to explain to consumers. So this is the challenge before us. It's probably not a simple answer of, yes, we should always obtain consent, or no, we don't need to obtain consent anymore. It's probably a combination of that, and it needs to occur in the broader context of educating consumers and providers about their rights. What gives me hope, though, is the potential for local partnerships to lead the way. You'll hear a little bit, I in a few moments from Jeff Chang, who has really pushed this initiative and really been on the leading edge of this. He'll probably talk about some of the work in Washtenaw County around this. Many of the local efforts in different parts of the state have helped informed our statewide approach, and I really think that's the key to figuring out how to balance Public Act 129 and Public Act 559. There's also the potential for technology to help improve and strengthen the consent process. So like I mentioned, no matter what happens with Public Act 559, there will still be instances when we still need to obtain consent, and we need a better process for doing that. And technology can help us get there. Kathleen will speak to that, but I am really looking forward to what our local partners can help us navigate, as well as the potential for technology to help us solve part of this problem. So that's all I have for you today, and thank you for letting me share my lessons with you.
Thanks so much, Phil. Our next presenter will be Jeff Chang. Jeff is CEO of PCE Systems, a leading behavioral health information technology company in Michigan. PCE provides health IT services to clients across the service delivery spectrum and who encompass over 85% of the $2.6 billion Medicaid budget for behavioral health services in Michigan. Jeff has championed efforts to provide a creative, technical, and clinical solutions to bridge the physical health and behavioral health information divide, as well as help agencies navigate the clinical, legal, and technical challenges to achieving integrated health. I'll pass it over to Jeff.
Thank you, Shreya. Thank you, everyone, for bearing with me again at another Connecting Michigan for Health presentation. I was going to start with a quick introduction of PCE Systems, but I think Shreya did a nice job. Like she said, we do a lot of the health IT work here in the state of Michigan, focused on behavioral health and integrating health. We have basically what I considered a behavioral health information exchange, and that's why when MiHIN was really sort of coming and growing, and Jeff Livesey and Tim and I started to talk, it's been a really, really exciting road. I was up here, or not actually physically here, but when it was a little bit of a smaller group 5 years ago. This is my favorite slide. So it was 5 years ago, almost maybe 2 days different. And I put this up here because at that time we had built basically a consent-managed 42 CFR Part 2 compliant health information exchange. And that was exciting, it was cutting edge, it was new, it was something that I probably somewhat naively believed would just mean that all of the information between behavioral health providers and physical health providers would be flowing immediately and easily. Unfortunately, we've made a lot of progress, but it's been slow. It's been a lot slower than I've expected. And there's been some really exciting things that we've done, and we've been moving along and doing some exciting things. So my goal today is to relatively briefly give you guys a high-level overview of some of the new and exciting and interesting things that are going on in that behavioral health, integrated health space. So first thing that I wanted to kind of talk a little bit about is the varying levels of the DCH 3927. So that's the standard, I think that's the right number, right? Did they? When I put together these slides and I wrote it down, I was thinking, that seems that doesn't seem like it's the right number, but I put it on there anyway, so I apologize. So the adoption of the statewide behavioral health consent. Contrary, I think, to a lot of what people are hearing, especially at the highest levels, where there's a lot of pushback about the the adoption of the behavioral health consent. Within our electronic systems, we've actually collected across the state over 320,000 consents since its inception. That's something I think that is really important for those people here in the room to hear, because I have heard a lot of times, you know what, we have the statewide standardized consent and nobody's really using it. The fact of the matter is that actually there's a lot of people that are using it. We have 320,000 across over 30 to 35 of the largest behavioral health organizations here in the state that are using it. It really comes in the utilization of it really comes in three different flavors. One is that some agencies that have been a little bit hesitant about it have adopted it as a supplement to other consents. So they use their own consents for certain purposes, and then they use the statewide consent as a method for care coordination with primary care. So that's one sort of flavor of implementation. More and more, as this has gotten, all of the marketing and all the good work that DHHS has done and Phil and his group has done, as people have gotten more and more comfortable with it, the adoption has actually more and more gone to becoming the sole consent to share. It becomes more complex for clinicians and records people to know, okay, well, in this circumstance, I need to use this consent, and in that circumstance, I have to use this other consent. And then the third flavor is where this consent is actually being collected either by a behavioral health agency or by their primary care or community partners and registered in our electronic consent management system. So those are kind of the three major flavors of adoption that we've seen. That electronic consent management system, and this is a slide actually that I had from 5 years ago, it implements the actual standardized consent. I like to say it's the great-great-grandfather of the standardized consent, but it really operationally works the same way. But it implements the tracking of that consent electronically, and all of the consent directives and who's allowed to share what with whom, and all of that information, it tracks it electronically. And it serves as a gatekeeper to HIE access to behavioral health systems. Out of those the 10 PIHPs and the 46 CMHs, our clients represent 9 of the PIHPs and 36 of those CMHs, and it continues to grow. So we're able to serve as essentially an access point to behavioral health data, as well as a gatekeeper with the HIE, a gatekeeper for the available information that's within our electronic health records and our other health IT. So the evolution, let's talk a little bit about how things have evolved and where I think we are today. And this is a very, very, very slimmed down basic view of the world. Information exchange in the olden days, and by the olden days I mean maybe 5 or 6 years ago, was primarily done by fax and paper. Right? You go to a medical records department, if you even have an electronic health record, you go to a medical records department and then they go and they print out documentation for you, they verify consents and they fax them or they put them into envelopes. The goal is to move, what has happened, I think in the evolution in the past 5 years is I've seen a movement from that kind of paper-based exchange of medical records to data-based exchange of health information through things like portals. It's been sort of a little bit of a stopgap type of approach, but it's something that is easy enough for people to start using. Well, the problem with portals is that for agencies that have to log into 3, 4, 5 different systems, information systems, a portal is just one more information system that people have to log into. I was speaking with an agency, this is not really a healthcare agency, but they were talking about, just yesterday, they were talking about how in order for one of their staff to do their job, they have to log into 11 separate systems. And we were talking about data integration, and it was really interesting. One of the things that I told them was, I don't want whatever data integration that we're going to be doing to make that 11 into a 12. The hope through data integration is that 11 becomes 4 or 3 or hopefully 1. So the end goal is ultimately full integration into a system, so that your staff can live, your clinical staff can live in one electronic health record. That's really, the thing that we're trying to achieve here. The progress that we've made so far, and as Phil alluded, and I think that those of you who have come to the Connecting Michigan for Health presentations before, you've heard a lot about what Washtenaw's done. That's expanded in the past year. As well as some other pockets, but really the focus here has been Washtenaw. That's expanded to actually the SIM project in Washtenaw and Livingston counties. So Washtenaw and Livingston County is one of the SIM shires, I think is the term for it. And through that has really propelled a higher level of utilization. So we have about 30 or 40 different agencies community agencies that are logging in community resources like housing assistance, social services organizations. All of these different organizations are actually logging into this MyCareConnect system and being able to put in consents and being able to see substance use treatment information and other types of information. They can use it to access the Great Lakes Health Connect Viper system. So there are all kinds of ways to get that data into to that place. And the way that it does it is through again, a portal. It's not something that I'm I'm proud of, but it is something that has allowed us to make some progress, right? So the portal gives you, the MyCareConnect system provides a portal access to the electronic consent management system as well as those HIE resources. So you can see in my little diagram here, we have an exchange partner A that logs into the portal. They can ask for information and see no information, and then register a consent and actually get that information. Or if the consent has been registered by another agency, they can just go into the portal and see it, but they have to go through that portal, and that's something that is, I would say, been a frustrating piece of the puzzle for me. The other really neat thing that we have worked on and built out on that MyCareConnect platform is, over the past few years, we've really been trying to get people to adopt it and get onto it and share data and get data access to it. But what it's really blossomed into over the past year has really been a care coordination platform. So all of these community resources aren't just logging into this thing and looking at data, but they're actually collaborating on treatment plans. They're creating care teams, interdisciplinary, interagency, community-based care teams that are able to wrap services around a consumer beyond just sort of you're being seen at this agency and that agency, and maybe we talk every once in a while. They're actually developing together care plans and referring consumers from one agency to another agency, all within this platform. So that's something that has been a really neat thing that the MyCareConnect platform has grown into. So it's not just the data sharing platform, but as the data sharing, that data sharing informs treatment planning and care coordination, and then it is that communication platform for them to be able to do that care coordination and case management. What I'm more excited about is non-portal based exchange, right? The right-hand side, I think it was the right-hand side, the right-hand side of that, of those arrows. And it's something that I think naively when I first got into this health information exchange thing, looked at all of the documentation that HL7 had and IHE had, and I thought, oh, there's these APIs and everybody's just gonna be able to implement them and it's gonna be a great thing. The reality of it is that for a number of reasons and time and resources and priorities and all of these other things, it's really hard to get people to do it. Well, we were lucky enough to have one of our clients and their local health system. So my client is Summit Point Community Mental Health. They are the CMHSP out in Battle Creek for Calhoun County. And their regional health system, Bronson Healthcare, they got together and they started to say, you know what, I'm tired of faxing. I'm tired of doing all of these things by hand. And I have to say, both Bronson as well as Summit Point were willing to invest the time and the effort into building a true non-portal based exchange. So this is an actual integration between the PCE EHR system that Summit Point uses through our HIE into their the Bronson Healthcare System's Epic system. So we're actually being able to use query-based protocols to using these national standards for a Summit Point clinician to be able to say, hey, you know what? I'm sitting here with Phil, and he's receiving services, and I'm wondering if maybe his med list changed, and they can click a button, and they can actually see the med list coming from the healthcare system, and likewise from the healthcare system, they're able to ask exactly those same questions directly within their EHR through Care Everywhere. It's just the kind of the Epic thing that is their way of interfacing through Care Everywhere, and they can ask that same exact question, and assuming that there is a consent in place, and that's a key element of it, assuming there's a consent in place, and they're able to see Phil's information over at Bronson, and we have all of that information in there, the system will automatically say, someone from Bronson Healthcare is asking for information about Phil, and I have a consent to share that information. Let's send the med list. Let's send their treatment plan. Let's send their allergies, their diagnoses, and potentially even more. So this is really the goal, the end goal. I shouldn't call it the end goal, but this is really the direction that health information exchange really should be going in, right? Where someone can stay in their home EHR without having to log into a portal, without having to do some other additional types of things, and use the technology and the functions that are within that technology to be able to access the information. This is revolutionary, I think. I don't know how many people across the country are doing this type of exchange through a 42 CFR Part 2 compliant mechanism with the electronic consent management and all of those bells and whistles. It's in its infancy right now. We're basically, all of the technology is ready to go. We're making sure that all of the clinical staff are trained and they know what they're doing, but this is something that has been really exciting, and I've been, really been pushing for the past 10 years. Next steps on that particular interface, as well as some of the other things that we're talking about. First thing is with Bronson, what we want them to be able to do is find a way so that they can electronically register their consents through their Epic system. And so we're going to be working with them and Epic and some of their internal resources so that that consent, not only can they ask the question, but now they can push that consent with all of the consent directives into our electronic consent management system. That's going to be some work, and that's something that I think we're all really looking forward to make that just one step easier. The other thing that we're really excited about, and I've just had some conversations with George Bosniak over at Great Lakes Health Connect, is integration with the Great Lakes Health Connect virtual patient record using these same types of transactions. It is, again, one of those things where it's really nice that we can log into the Viper system and our clients can single sign on into it and see all of this information. I think that that's really, really great for data integrate or for care coordination. It's not really data integration. And so the recent announcement that is a capability that we're going to be able to do with Great Lakes Health Connect is, again, one of those drivers to propel this type of project forward. So the struggle is real. And I love the idea that I actually hate the idea that if my arms were so small I couldn't get to the hamburger. It kills me. But this whole process, like I said, has been a lot slower than I expected. And I get up here and I do presentations a lot of times about the barriers. But there's a lot of barriers to actually implementing this. This is why it's been so slow. And consent management's just one piece, right? I've technically solved the consent management problem. But consent management also is all of the hard work that Phil and his team is working on, right? It's the how do we make the consent more consumable for your consumers and understandable. But that's just one piece of the puzzle, right? Every agency and every vendor has their own technical requirements and their technical priorities and all of those types of things. And I'm not saying that this should be everyone's number one priority, but you need to get those priorities to line up. And a lot of agencies have limited resources. The things that we're talking about doing, the amount of data that we're exchanging, and the amount of lift and work that's put into these projects, it's great. And you have to actually have people who are able to and willing to invest those types of resources and move it forward. And as well as agencies have varying, motivations. And I don't mean this, again, in a nefarious way, but there are, do I spend my time chasing CCBHC? I'll just use that as an example. Or do I spend time integrating? Or maybe those are two projects that kind of play hand in hand together. But every agency has a lot of things that they need to do. It's a question of whether or not we can prioritize that. And then adoption of standards is really driven by a lot of these considerations as well. So, ultimately, where we are today, I think we're in the process of eliminating more and more of that fax. I don't think we'll ever actually completely eliminate fax, but we're in the process of moving away from that. A lot of the care coordination is in portals right now, right? Be it CC360, MyCare Connect, Viper, or whatever other platforms are out there. And I think we're starting to get into that full integration world, right? My goal and where we want to be is to start eliminating more and more of that fax and start to eliminate more and more of those portals, so that that full integration is a reality. And I didn't put this in a slide, and I should mention this. This is also one of the things that we've been working very hard with the department, MiHIN, Optum, as well as Bay Aranac and some of our other clients, to integrate with the CC360, so that access to CC360, the Care Connect 360 data, doesn't have to be through a portal, but can be done through home EHR. So we're moving in that direction. It's been a little bit slower than anybody would hope, but I think that I feel pretty confident saying that I think that the state of Michigan here is on the cutting edge of this. So even though we're slow, I think we're winning the snail's race. So that's what I've got.
Thanks so much, Jeff. Finally, I'll be introducing Kathleen Connor. Kathleen is a subject matter expert in health policy, insurance, privacy, and security IT standards. She has held policy and IT positions with the State of Washington Insurance Commissioner and Washington Medicaid. She is currently co-chair of the HL7 Security and HL7 Financial Management work groups. Kathleen has also consulted on HIPAA with the U.S. Department of Health and Human Services, Office of Civil Rights, and Center for Medicare and Medicaid Services. She has also provided privacy and security technical and policy expertise to ASPE, Office of the National Coordinator, Substance Abuse and Mental Health Services Administration, and the Department of Veteran Affairs. Kathleen, I will hand it over to you.
All right, I'm very happy to be here, and thank you, Shreya, for the introduction. It was probably more loquacious than it needed to be. Great presentations by co-presenters here. Actually sets the stage for the things I want to talk about. And the main theme is what happened on the way to granular choice. I've never used one of these, so let's see how this goes. So the topic is, what is granular choice in data segmentation for privacy? We're going to call it DS4P. That's the people hear DS4P more than they hear data segmentation for privacy anymore. The milestones to enabling computable granular choice and demonstrating a landmark milestone in this list that I will run through for enabling computable granular choice was achieved by MiHIN's successful completion of the ONC granular choice pilot. So what is granular choice? What is DS4P? Well, you have to start with foundation for many of our privacy laws, and it's integral to the policies behind the effort to enable computable granular choice. And those are called the Fair Information Practices and Practices Principles. A lot of countries have their own frameworks for privacy principles. These are the ones we use in the US. They influence all of our privacy laws, basically, even at the state level. And they're several principles that are very key to saying we should be supporting, by policy in our framework, granular choice. And the first one is individual choice, that individuals have an opportunity and capability to make informed decisions about the collection, use, and disclosure of their information. And the second is the collection, use, and disclosure limitations, that individuals should be able to control how that information is used and disseminated. So these are the components that make granular choice something we need to do by policy. It's something we afford patients under many state and federal laws. Computably integrating granular choice is actually doing that technically is called data segmentation for privacy. And there's some key pieces of the technology that are required, which includes security labeling, which I'm happy to say Phil is working in. I work with Phil and Shreya in the privacy tagging work group. Oh, and Jeff, sorry. And we are talking about what it takes for MiHIN to actually implement security labels with the privacy tag, which are meta tags, they're just codes that represent for a computer system and an access control system what the policies are that apply to a particular piece of information. And that's one of the things you'll see in this demonstration today. The other part is also provisioning users so that they are given access at least privilege. And that also involves using privacy tags to indicate, for example, that care teams, who may be across several enterprises, as Jeff just described, will know what information they can access based on a consent directive, while other members in that clinic may not be able to get it. So you use that piece of the code, and you match it to the resource, and you use computer access control systems, the gateway capability that Jeff was just describing, and you can limit, or actually what we'd like to call share with protections, and enable the enforcement of consumer choices. So there are a lot of perspectives on granular choice, some pro and some against. So on this side, you're going to see sort of the basic, oldest statement about being able to sequester or segment your data that comes from Hippocrates. The next one is one that MDs or osteopaths and many medical professionals sort of attest to when they are entering the profession, which is to protect the privacies of their patients, and their problems that are disclosed to them are not there for the world to know. And the other one is Dr. Blumenthal, who recently wrote an article saying, if you want HIE to happen and you want people to share their data and not withhold it, then you need to support sharing with protections and ensuring that trust can be established, that the data gets to the right people at the right time, and the patients are basically not surprised about how their data was used. They should always meet their expectations. That's also involved with educating, the kind of education that Phil's been talking about, informing people about the risks they might be assuming if they don't share, assuring them that there are the protections in place to enable them to make choices to share behavioral health as well as with their physical health. So on the other side, and this is a very valid perception, strongly held by major communities, one is called making Swiss cheese out of medical records, a favorite saying. There's a lot of people that say it biases research. One of the things that was discussed in deliberations around precision medicine was that we need to get rid of all these additionally or especially protective laws because we are not getting information from individuals who have behavioral health issues, so we can't do our research. It's biased, but there are a lot of articles and studies that say that that's not quite true. There are people that say it's impeding healthcare quality improvement and value-based purchasing, and that's another camp that would like to see these laws go away. That it fuels the opioid crisis. It's one of the biggest arguments you'll see when you look at legislative discussions about ending 42 CFR confidentiality protections. It was actually very effective recently where they just passed a law that eliminates those confidentiality protections. I won't say confidentiality protection, I'll say it differently. The need to get authorization from veterans who have sickle cell, HIV, substance use disorders. There's a law that says you need their consent. They have eliminated that. It's on the president's desk. It hasn't been signed, but it's one of the precursors we imagine for seeing 42 CFR also being removed. And then they also say it's a barrier to innovation. We want people to have this data, to be able to do all sorts of wonderful apps to help providers and consumers control their health care. And the last one is it sandbags data liquidity, and a favorite saying currently, which is having all the data all the time, everywhere. So those two sides of the coin. Okay, so now I'm going to go through the milestones that I've been involved with happily for the last 20 years that have kind of culminated in what we're going to see today. The National Association of Insurance Commissioners created a Health Information Privacy Model Act in 1998 under Kathleen Connor's leadership at the NAIC. And it was a consolidated view of all the national health policies to make it become part of the ability of insurance commissioners to support consumers when their data was being shared among health plans in particular. That was sort of one of the first overviews that happened. And that fed into some of the work that was going on technology-wise about, well, how do we, make these laws enforceable? And one of the first was the HL7 Security and Privacy Domain Analysis Model. It has been foundational for a lot of work that has happened to date, including the demonstration you're going to see today. It was a conceptual model, and it was based on a lot of standards and policy frameworks, like I just mentioned, FIPS, internationally. What it does is set the foundations for how you make it operational in a computer world. So there was a group formed by ONC and I think federal law called HITSP, and I don't know if anybody remembers HITSP, but it was the effort, and HIMSS was very much involved with it, to come up with standards for actually implementing interoperable exchanges using the current standards. So they would profile the standards and say, this is how you take care of privacy, security, and a number of other ones. And there was an important two pieces that came out of that. One was for privacy, in particular for supporting consent. The other was for security that would enforce that consent. And again, the two pieces you need is the security system that is able to recognize the privacy policies that are made computable and actually enforce them. So the next one, when HITSP kind of went away, was the ONC started the Data Segmentation for Privacy project, and this was after there had been a national survey of privacy laws, very much like what had happened in the NAIC. And they brought together a lot of stakeholders to decide how could this happen and what were the requirements. And then they moved to actually building a standard to do that, which is the HL7 Data Segmentation for Privacy CDA Implementation Guide. And there are ways in which you can take your CCD and actually apply these privacy tags in the document to say, this is 42 CFR information in this document, and share it accordingly. Then the next move was to standardize the security labels that are basically that's the syntax in which you put the codes that we call privacy tags. And there's a standard for that has been picked up by CDA, FHIR, and now we're on the cusp of having it in V2. So you could put it on your ADT messages. What's valuable about that is because those codes are interoperable, you can transform across those different syntaxes and still preserve and persist the privacy policies. So then the HIT policy, security and privacy tiger team sent ONC a transmittal letters recommending that DS4P become a national standard, but they proposed a glide path, so that it wasn't like you had to do everything tomorrow. It was what is the way to reach the low-hanging fruit. And then about the same time, they incorporated DS4P for using the CDA standard as an optional certification standard under Meaningful Use 2015. And then there's the Interoperability Roadmap, and I didn't finish this presentation until about 15 minutes before this presentation, so there's a little glitch there. So it was very important that after that transmittal letter, ONC said, yes, we agree with HISP's findings, and that patients should be able to understand their choices and the impact of the choices that they make when they share their information through an HIE. So they came up with three sort of definitions or concepts. One is basic choice, which is the idea that you opt in or opt out of an HIE. Granular choice is when you can make further restrictions on the way in which data may be shared. So you can opt in except for a certain organization, for a certain set of information, for certain purposes of use. And finally, they arrived at what they considered sort of a definition of data segmentation, which is the ability for an EHR to capture, adjudicate, comply with, and persist downstream. So processing of information downstream in the processing of information of an individual's documented choice, i.e. what was in their consent directive, and have that be available for electronic exchange in a learning health system. So this is, again, the idea of let's share with protections. Let's not just sequester and say that behavioral health information cannot be moved with physical health through the HIEs and across multiple HIEs, and they talk about this in TEFCA. So that's why it's very important that the outcome of the project, that this roadmap was one of the components of the roadmap, actually spawned, and that was the ONC Patient Choice Initiative and the idea of sharing with protections. So it focuses on technical standards, but they also had a piece that did the policy analysis as well. But the part I was involved with was the technical part. And we came up with, we knew the needs to implement and share individual consent, so we had a number of use cases, both for basic, granular, and research consent, and to harmonize the technical standards and promote new technologies to advance the previous work of all those milestones that we went through before. And just so we could show how HIT's health information technology can honor patients' preferences for sharing their information. So it enables sharing with protections with electronic patient consents and by persisting consumer choice, ensuring that those consents are interoperable, can be shared across different exchange partners, and enforcing the policy by using the standard privacy tags. So MiHIN has been involved in both the basic and the granular choice pilots. The first pilot was very much the opt-in, opt-out approach, but they demonstrated their initial, current approach to behavioral health sharing using the consent form. If you opted in for behavioral health, it was a basic choice. You couldn't say only my mental health part of my behavioral health or only the HIV treatment I got under Part 2 facility. It was all in or all out. They actually piloted with the VA in a project I was on and with SAMHSA, and this work was showcased and got a lot of reviews in HIMSS 2017. So after reviewing the candidate HIEs out there, ONC decided that MiHIN, probably because they did such a good job on the basic choice, should be awarded the grant for the granular choice in 2017. And they successfully completed, and they'll show you with this outstanding demonstration, their ability to create use FHIR resources to take what you see as the paper consent and make it available electronically to consumers, and to do that not just opt-in or opt-out, but to actually start making granular choices. And then they show how the receipt of that information by a disclosing entity who is asked, can I share this information? They said yes. They put the privacy tags on ADTs and on the MedRec CCDs. So they're going to show you that. So we're seeing FHIR, V2, CDA, all using security labels. And so now, it's my personal pleasure, having been involved with this for 20 years, that I'd like to introduce a demonstration, and I want to turn it over to the demonstration and to the two wizards who have been part of the patient choice pilot who are behind the curtain. So Summer and Paul, over to you.
Thank you, Kathleen. Thank you, Kathleen. Good afternoon, everyone. Today we will be demonstrating a patient's privacy choices using an electronic consent management service, or ECMS. This service has an electronic consent, or e-consent form that allows patients to manage how their most sensitive private information can be shared only with health providers the patient names on the form. We call this private information specially protected information, or SPI. SPI is any information that requires patient consent to be shared, such as under federal or state laws. Examples of SPI include various behavioral health information related to conditions such as substance use disorder. Some states have statutes specifically protecting other information such as mental health conditions. Written consent is typically required to share SPI, and this demonstration shows how an electronic written consent form can be used. With the e-consent form, patients update their consent preferences using online tools to identify which healthcare providers may send and receive which types of health information. When patients update or change their preferences on the e-consent form, the consent metadata is saved in the ECMS. Once this metadata is saved in the ECMS, whenever healthcare providers wish to send an update about the patient that contains SPI, they can query the ECMS to see if a valid consent exists for the provider to share that patient's SPI. The ECMS will yield a yes or no response to any query for any patient, telling the provider either there is a valid consent for that patient or no valid consent was found. This response indicates whether the patient has given consent to that provider to share that patient's specific type of SPI. If a yes is returned, the provider first adds privacy tags to the SPI and may then send the SPI electronically, such as to a qualified health information network, under the Trusted Exchange Framework and Common Agreement under the 21st Century Cures Act. In Michigan, when the statewide health information network receives the SPI and detects the privacy tags, the HIN routes the selected approved information to other providers on a patient's care team who have been given consent, and denies sending to those who have not. The HIN accomplishes this by querying the ECMS, finding all the patient's named recipients from the e-consent metadata, and sending electronic copies of the tagged SPI only to those named recipients. Together, the e-consent form and the ECMS allow SPI to be shared electronically while in full compliance with the patient's choices and privacy laws. For this demonstration, 2 simulator applications will be used to send Alice's health information to the HIN. Her transition of care information will be sent via the HAPI test panel in HL7 V2 pipe delimited format. And her medical visit information will be sent via postman in XML format. These applications will be displayed for each of Alice's visits throughout the demonstration.
I'm Alice Vargas, and I really want the past to stay in the past. Since returning from Afghanistan, I've had some problems. The war was hard, and I live with it every day. My leg injury is proof of that. There was some drinking, I'm not proud, and I was introduced to painkillers for my leg. I built up a little problem around them. I'm trying to start a new life now, and the last thing I want is my past following me everywhere I go. Keeping my healthcare information private is very important to me. I go to an opioid treatment facility where I work with Dr. Daniel Carlman. He's a great doctor. He understands that I'm trying to start over and showed me how to protect my history with drugs using Michigan's electronic consent form. He called this patient choice. Now, only the doctors I choose get to know about my challenges with opioids. I really value the power over my information that I get with patient choice, and I stay on top of it to make sure that the right information only goes to the right people. So when I'm done with the opioid treatment facility, those addictions can stay in the past.
On April 6th, Alice has abdominal pain and goes to a new provider at a 42 CFR Part 2 facility, Dr. Erica McCoy. An admission notification is generated by Dr. McCoy's office upon her arrival, seen here on an electronic health record simulator. The message is sent to the HIN, where it identifies Alice's entire care team and routes the message accordingly.
My stomach has been giving me some grief for a while, so I decided to go to a new primary care doctor named Dr. Erica McCoy. She's at Peachtree Family Practice, and I've heard some good things about them. Dr. McCoy takes some time to get to know me and does a thorough exam. She isn't sure what's wrong, so she gives me some stomach medication to start. It feels good that she's being thorough and spending time with me.
Dr. McCoy's staff adds Alice to their patient roster in their EHR system. A message is sent to the HIN to add Alice to Dr. McCoy's active care relationships, meaning Dr. McCoy would like to receive updates on Alice's health information messages that pass through the network. As a note, Alice has not given consent for Dr. McCoy to send or receive SPI, so Dr. McCoy is unable to receive information protected by 42 CFR Part 2 or information protected under state mental health code.
I asked Dr. McCoy about the new drug she gave me, and she tells me it should be okay. She also tells me that the other doctors working with me will be able to see the medicine she prescribed too, so if they have any concerns, they can give me a call.
When Alice checks out, since her visit did not involve SPI, Dr. McCoy's EHR, seen here as an EHR simulator, sends a normal admission discharge transfer notification, or ADT, to everyone on Alice's care team. A continuity of care document, or CCD, is also sent to everyone on Alice's care team in CCDA format, either at or soon after the time of discharge. Staff in the offices of Dr. Carlman and Dr. Simon regularly use a tool where they can view health messages received from around the state for their patients. At this stage, we'll see Dr. Carlman's staff member use this tool. Please note this tool could be embedded in an online EHR or accessible via single sign-on from an EHR. Dr. Carlman's staff noticed that Alice has an ADT notification and a care summary from her recent visit with Dr. McCoy. They can view all this information as these updates are all classified as unrestricted message types. They notice that the security classification for the AO3 message is tagged as normal. You can see that highlighted here. They then click on the care summary for the visit. And using a simple display, they can see the CCDA in a human-readable format. It is important to note that all sections of the CCDA are viewable in the table of contents. Once the staff has read the messages, they log out of their account.
I'm getting a little worried that the opioid meds I've been taking are messing up my stomach, but I didn't tell Dr. McCoy about them. I really like her, so I decided to give her more details about my treatment. I think I can trust her. When I get back home, I open my patient app and add Dr. McCoy to my consent form, so she has permission to send and receive my medication information and drug usage history.
Alice adds consent for Dr. McCoy to share SPI using tools available through her consumer app or patient portal. First, she logs into her account. Please note the electronic consent form can be embedded in any portal, such as a health plan's member portal, or can be accessible via single sign-on. Alice notices that on the first screen, she can see and manage all her active care relationships. She clicks the consent tab to open the electronic consent form. Under Michigan law, Public Act 129, all healthcare providers in the state must accept this electronic version of Michigan's standard consent form for behavioral health information. There are typically 6 main demographics used for identifying patients in healthcare, including first name, last name, date of birth, gender, zip code, and the last 4 digits of social security number. The e-consent form collects all 6 of these key demographics for accurate patient matching. When Alice enters enough information to be matched by the HIN, the ECMS can query the HIN to find the patient-provider attributions that make up her active care relationships. These attributed providers can be used to automatically pre-populate the named recipients on the e-consent form. The ECMS also queries the statewide health provider directory to find accurate information for each provider to pre-populate each field. This ensures the information for the providers is always accurate and eliminates handwritten or typed mistakes. This also ensures the correct electronic address for the provider is used. It's important to note that the name of the HIN is also hard-coded into the electronic consent form as a named recipient pursuant to the recent final rule from SAMHSA on 42 CFR Part 2. Previously, Dr. Carlman, Alice's opioid treatment provider, was the only doctor listed to receive her SPI. Dr. Simon is not listed, so he will not receive SPI for Alice from the HIN. As mentioned before, the named recipients and the other fields are pre-populated by the statewide HIN using Alice's active care relationships so that Alice does not have to manually enter the information, which can result in errors and omissions. And not only is the information accurate, but it includes unseen electronic links to the full provider record in the health directory. And finally, Alice can more easily add, change, or delete the information, resulting in a friendlier user experience and better adoption of e-consent. Alice clicks the Add button and searches for Dr. McCoy using her last name. She sees that the name Erica McCoy from Peachtree Family Practice populated from the health directory and checks to make sure it is the correct address. She selects Dr. McCoy and now sees her name updated on her consent form.
Now that I've added Dr. McCoy to my consent form, I can choose which parts of my health information she gets to see. I'm comfortable letting her know what medications I'm taking for my addiction, but I'm not sure I want her to know my full history yet. Giving this permission is not easy for me, but now she can share medication information about my substance use. I let her into a private part of my life.
Alice uses the electronic consent form to choose which types of SPI she wants to share with Dr. McCoy by clicking the Choose Health Information button. Alice can choose to share SPI related to transitions of care for when she's admitted or discharged to a care facility. She can also choose to share all her medical visit information or just information on medications from the medical visit. Alice decides to only share medication information with Dr. McCoy, so she selects Do Not Share under Transitions of Care, share only medication information under the medical visit section, and clicks OK. Alice scrolls down to the bottom of the page and notices pre-populated questions that are required by law to be included on the consent form before she clicks Save and logs out.
When I save the consent form, it automatically stores my consent preferences. I also have the option to generate a printable copy of the form that I can take to any doctor in the state if I want.
On April 11th, Alice goes to her follow-up appointment with Dr. McCoy. Upon arrival, an admission notification is generated and sent to her care team. When she arrives, no SPI is generated, so the message is sent to everyone on Alice's care team, like her first visit.
During my follow-up visit to Dr. McCoy, I share my past around opioids and substance use. It's a good thing I do, because Dr. McCoy explains that my stomach pain might be related. If I hadn't decided to share this with her and add her to my consent form, my stomach pain could have turned into something much worse. Giving consent might have really saved me.
The EHR in Dr. McCoy's office generates the AO3 and CCDA messages and adds privacy tags, as specified by HL7 in the security label fields, to send through their EHR system, as seen in this simulator. Taking a closer look, the tags can be seen here, where there is a high watermark privacy tag in the MSH26 section of the AO3. In this case, the high watermark is an R, indicating that there is restricted information in the message. Additionally, the Access Restriction segment, or ARV segment, identifies which pieces of information in this message are restricted. While these tags are in the message to specifically identify SPI, for this pilot, messages are checked for privacy tags at the high water mark only. Please note that based on the recent SAMHSA rule, the disclosure statement is in the correct section of the ADT seen here. The CCDA also contains privacy tags, seen here in this privacy section, which identifies each piece of SPI. Similarly, the disclosure statement can be found here. Recipients of health information may not redisclose substance use disorder information, which is protected under 42 CFR Part 2 without the patient's consent. Now that the messages have been tagged, Dr. McCoy's office can query the ECMS for active consent on file. Their systems build a FHIR query with key demographics, which they use to send a query. They see that a yes value is returned and send the messages. If one of Alice's key demographics is altered in any way in the FHIR query, indicating a different patient, a no response will populate, meaning there is no active consent on file and the office does not have permission to send. Through their regular work processes, Dr. Carlman's staff can log into their account and see that the protected messages sent during Alice's second visit on April 11th are readily available. Once they are logged in, they click View Care Summary and can see a full summary of all information acquired during Alice's visit, including the information surrounding her substance use disorder, seen here as opioid dependence uncomplicated. The office staff view the message and log out. Another member of Alice's care team, Dr. Simon, has not been added as a named recipient on Alice's consent form. Dr. Simon's office staff log into their account during their normal day routine. Dr. Simon's staff can view unprotected AO1, AO3, and CCDA messages from Alice's April 6th visit, as well as the AO1 submission notification from the second visit, but not the AO3 or CCDA that include her SPI. Dr. Simon's staff notices nothing out of the ordinary and logs out.
After going through all that pain before my treatment with Dr. McCoy, I decided to visit Dr. Carlman at the opioid facility to really try and get a handle on my drug problem. It's easy for me to talk to Dr. Carlman because he already knows about my visits with Dr. McCoy. He prescribes me some new medication to wean me off my addiction. It feels really reassuring knowing that I have an entire team watching and caring about me.
On April 13th, Alice visits her opioid treatment facility and sees Dr. Carlman about quitting her drug addiction. Upon Alice's arrival, a protected AO1 admission message is created and sent. When Alice's visit is complete, a discharge AO3 and a CCDA are created. These messages are again tagged as containing SPI using the same high water mark and ARV section. Dr. Carlman's EHR sends the messages. When Alice's visit is Now, when anyone on Alice's care team does not have consent, logs in, such as Dr. Simon, they are unable to view the messages. When Dr. Simon's office staff perform routine checks in their account, they can only see non-specially protected messages from Alice's first and second visit. They log out as no new information is available. Dr. McCoy's office logs in during their routine checks. They see that Alice has been to Dr. Carlman's office, Arborview Treatment Facility, today, as there is a care summary available from the visit. Note that because Alice did not give Dr. McCoy consent to view transitions of care information, there are no AO1 or AO3 messages that the office is able to view containing SPI. They click on the care summary. Since Alice chose for Dr. McCoy to only see her medication information, they are only able to see the portions of the message that contain information regarding her medication. They note that her new medication does not conflict with the medication Dr. McCoy prescribed, and log out. What differentiates this demonstration from others is that the ability to parse messages based on a consumer granular choice.
I'm comfortable knowing my information is being shared with Dr. McCoy because it's on my terms and under my control. I feel safe knowing that at any time I can change my consent preferences to allow more or less access to my personal health information. I used to be hesitant about seeing new doctors and healthcare professionals because I didn't know what they could or could not learn about me, my struggles, and my past. Now that I know I have full control over who can see my sensitive information, I have more confidence in the healthcare system, and I feel more comfortable reaching out to experts who I know will be able to help me with all of my healthcare needs, even if I'm not proud of them. Patient choice has given me the freedom to make my own decisions about my health information, and my concerns about privacy will no longer prevent me from seeking treatment in the future.
Thank you so much to Summer, Preston, and Paul for that very comprehensive demo. I know that we're already running about 15 minutes over, so in the interest of time, we kindly request that everybody send all of their questions to connectingmichigan@mihin.org. I also think that a lot of our speakers will be attending the networking event after the sessions today, so that would also be a great place to ask some questions. I want to thank these three panelists and also the three members of MiHIN for the demo.